O2 sats, oxygen saturation. How do we document this in a clinical setting? What exactly does it mean? And where do we need to exercise some element of, not necessarily precaution, but take certain things into consideration? So, to understand what oxygen saturation actually means, let's go back to a little bit of basic physiology. The red blood cells which carry oxygen around our body. Red blood cells are one of many types of cells that are specialized in their function, and the specialization here is such that they are anucleated. They do not contain a nucleus. This allows for maximum capacity for hemoglobin molecules, and as such there are approximately 240 to 250 million hemoglobin molecules per red blood cell. That depends on what reference you read. My reference is Frederick H. Martini, Fundamentals of Anatomy and Physiology. The hemoglobin molecule the hemoglobin is what gives the red blood cell its red colour, the red pigment, and as I said, hemoglobin it is that carries oxygen in the red blood cell. Each hemoglobin molecule, and I'm not going to go into the microbiology here, but let's just appreciate it's a quaternary structure protein made up of 4 polypeptide chains, 2 alpha, 2 beta, and I'm going to stop there. Each hemoglobin molecule can carry 4 molecules of oxygen, i.e. 8 oxygen atoms, because oxygen is a diatomic molecule. Saturation means how much of that hemoglobin is actually carried, is actually carrying oxygen. Hence, oxygen and hemoglobin makes oxyhemoglobin. And so, the greater the amount of hemoglobin that is carrying oxygen, the greater the saturation. And that's what we appreciate. Moving on. How do we then document O2 sats? So for what is normal O2 sats? Normal O2 sats are between 94 and 98%. This is in the average healthy adult human being. Most adults will measure at 98% O2 sats on room air. Some may go above that, and that's absolutely fine. However, there are certain conditions whereby we will normalize the range for the oxygen saturation to be between 88 and 92%. A typical case of this might be patients who suffer from chronic obstructive pulmonary disease, COPD. However, this should not be generalized, because what you find is we will only adjust this oxygen requirement if the patient is a chronic retainer. And what we mean by that is if they retain carbon dioxide. We can only assess chronic retention of carbon dioxide by means of a blood gas. Going through blood gas is beyond the scope of this video, so I'm going to leave that for another time, another day, and explain how it is that we ascertain whether an individual is a chronic retainer or not. When we're documenting O2 sats, we will, in order to actually attain this value, we will use a pulse oximeter. The pulse oximeter is typically applied to the distal phalanx of one of your fingers. It doesn't matter which, any of the distal phalanges, we will apply it to the tip of the finger, the distal phalanx. There are certain situations, for example, when somebody has got nail polish on, and that may well affect the readings. There may be other occasions such as a seizure activity, a primary tremor, for example, if the patient suffers from Raynaud's phenomenon and they are having an acute exacerbation. So these situations, hypovolemic shock, hypothermia, these situations, and it may well become difficult to take the pulse oximetry. Certain situations, such as babies, or even like I say a seizure, we can then use a different probe, what we might use in pediatrics, and apply that probe to the earlobe, and we can take the O2 sats from there. Certain situations we may even apply the same probe on the toe, if it's absolutely necessary. O2 sats, as I said a moment ago, are documented as whatever the reading is, so let's say it's 98% on room air, ORA. The reason being is because if the patient does not warrant or does not require any oxygen, that's great. If, however, the patient is on oxygen, then we must document how much oxygen they are on. Is it 1 litre, 2 litres, 5 litres, 10? And in the ward, we can give up to maximum 15 litres of oxygen, after which then we need to consider escalation of care. When we document how much oxygen, we must also document by which means that oxygen is being delivered. For example, the little tube that we have running over the lobes of the ear and in towards the nostrils is what we call a nasal cannula. So we will say 2 litres via nasal cannula, or NC in capitals for abbreviation. Other methods are by means of a Venturi mask. Once again, I'm not going to elaborate too much on the means and modes of oxygen prescription, again beyond the scope of this video, and I'll leave that for another time. But the point being, if the patient is on oxygen, the oxygen must be prescribed. We must document how much oxygen patient is on and by which means or which mode it is that that oxygen is being delivered. When we assess the oxygen saturation, say otherwise when we check the patient's blood gases, it's important that we consider the FiO2. FiO2 stands for fraction of inhaled oxygen. Let's again appreciate the oxygen in room air, on room air, is 21%. In the atmosphere, we have 21% oxygen, carbon dioxide 0.04%, nitrogen 78%, and so on and so forth. So the oxygen, 21% on room air. 1 litre of oxygen will change that fraction of inhaled oxygen up to 24%, and after that every litre adds 4%. So 2 litres of oxygen, 28%, 3 litres of oxygen, 32%, and so on, so forth. This must be accommodated for when assessing blood gases, and you will tap this into the computer, but again I will elaborate on that video. Last point to make, oxygen saturation. Can we over oxygenate a patient? And the answer is yes, you absolutely can. So too much oxygen can actually be dangerous. The risk of over oxygenating a patient is such that they may suffer from atelectasis, which essentially means collapse of the lung. So you can actually get the lobes of the lungs collapsing. Appreciate again anatomy: 3 lobes on the left, 3 lobes on the right, 2 lobes on the left. Assuming the lingular lobe is not seen as a lobe, that's an anatomical variation. And the other risk you can have is in COPD patients, you may actually cause respiratory failure because you will shut down the respiratory drive. And once again, I'm not going to go into the physiology of that, again beyond the scope of this video, and I will save that for another time. So there you are, oxygen saturation, what it is, what the normal is, under normal circumstances, in certain situations the variation, and what exactly it means, how we document it, and the risks of over oxygenating a patient. Thank you for watching.